Okay, lovely. Hey, folks. Welcome everybody. Glad you're here. We'll just wait a minute or two for people to trickle in. Good morning for those joining us from the West Coast and middle of the country, and happy lunchtime for those joining on the East Coast. Great to have you with us. We'll just wait a couple of minutes as people are trickling in. Thanks for joining us. Welcome, everybody. We'll just mute you all while everybody's coming in. Thanks for joining. We'll get started in about a minute.
John, you're muted if you're talking to us.
Oh, can you hear me now?
Yes.
Okay, thank you.
You bet.
I don't know if you heard any of that. I was
I could just see your mouth moving.
Oh, okay, yeah. It was damn it, that was the best thing I've ever said, as usual.
It was amazing.
Isn't it always the way? Hey, well, listen, I will repeat myself. It's just great to see everybody here. And welcome back. Welcome back for those of you returning to the next segment in our Recovery Science series. We've got a really terrific webinar planned for today. This is a webinar that's hosted by us at the Recovery Research Institute, but is sponsored by the Opioid Response Network and the American Academy of Addiction Psychiatry and SAMHSA at the head of it all. Next slide. We always start off the webinar just to put you in the picture of what the Opioid Response Network is. We have this like 1-minute video, so please hang on and get informed. It's just about a 60-second video about the Opioid Response Network, what it is and what it does. So take it away, Maya.
Agencies across the nation are mobilizing to address opioid and stimulant use and the overdose crisis. You can't overcome this alone, but we can, together, and we are. We are the Opioid Response Network, a coalition of 40 national organizations representing more than 2 million people. We serve all 50 states and 9 territories locally through our network of nearly 1,000 professionals working across prevention, treatment, and recovery. For state agencies, organizations big and small, and individuals working to address local needs, we bring training and education to bear on your efforts. We're here to help you help others through evidence-based support, all at no cost to you. For instance, the Opioid Response Network helped the Tribal College in New Mexico join forces with local organizations to develop a culturally appropriate prevention, treatment, and recovery training series for its students. In Rhode Island, we convened correction staff from 34 states to share how our program had reduced post-incarceration overdose deaths by more than 60% and supported them in their efforts to build similar programs in their home states. In West Virginia, we mobilized to help a clinic incorporate substance use disorder services into their practice, serving a faith-based community. We helped healthcare providers in South Dakota address barriers they face providing treatment services for their patients. We're here to help those on the front lines. So, what are your needs and how can we help? Visit the opioidresponsenetwork.org to learn more and to submit a request for support. The Opioid Response Network. funded by the Substance Abuse and Mental Health Services Administration. Communities across the
Right, we'll only play that once. We'll save it another one for next time. But thanks for that, Maya. Hopefully that puts you in the picture a little bit about what the ORN is and does. And if you go to opioidresponsenetwork.org, the nice thing about this is that it's completely free to you as providers, as clinicians, as agencies. You can get training and support, technical support and assistance on any aspect of care delivery and content for services from the network. So sign up, put a request in, spread the word, please. This is a freebie, courtesy of the federal government and SAMHSA. So it's a nice thing that we have to be able to address the opioid crisis and other substance use disorder challenges that we have around the country. So thanks, Maya, for that. Just as a reminder, we do have a growing archive of webinars here. Listed as some of them, 14 so far at recoveryanswers.org. So please avail yourself. Again, spread the word. We have some great talks on here, and including very soon the one from today with Dr. Steve Shoptaw. And before we begin, we just have a little poll that we'll ask you to fill out, Maya. So this just helps us identify, kind of who's here. So you take a minute, please, just to fill this out. And you have to scroll down to get to the next questions. And there's a couple of content-related questions here as well at the end, number 5 and number 6. So please take a second to fill those out. Kind of pre-webinar questions specific to the content today. Well, just a few more seconds because it'll take the last couple of questions take a little bit of thought, a little bit more thought, I should say. How are we doing, Maya?
Good. We are about 50% participation, so I can close the poll and share the results with people.
All righty. Right. Okay. So we got some answers there for the. All right. Steve is going to enlighten us today on the answers to these questions. So with no further ado, thank you so much, everybody, for filling that out. I don't know why we've got these lines popping up on the screen. This has happened before, isn't it? These for some reason these lines are not supposed to be there. We're not trying to damage Steve's reputation here with these scribbles. Somehow they appear on the screen, these red lines. I don't know where they came from. But anyway, we're so honored to have Dr. Steve Shoptaw with us. Steve's been a champion in the field for many decades, and he is a clinical psychologist by training, but he holds the George F. Neller Term Chair for Family Medicine at UCLA. He's director for the UCLA Center for Behavioral and Addiction Medicine and the Center for HIV Identification, Prevention, and Treatment Services, and is MPI for the Big South and West Node of NIDA's Clinical Trials Network. Dr. Shoptaw leads research, clinical, and policy efforts to bring novel and high-impact strategies to deliver culturally competent care and prevention for persons affected by addictions and HIV. And he provides mentorship to clinical and research scholars from diverse backgrounds in the US and globally. And we're so honored, Steve, that you made time today to share your expertise and wisdom in this very important area. So I'll hand it over to you, Steve, and thanks again.
Thanks, John. Thanks, Maya. It's really my pleasure to be here today. let's see here. Let's see, bring this up. Oh, where'd it go? Okay, now you should be able to see my screen. Thanks for the very kind introduction. I've been working in the field for 30 years or so, and I actually have some things to tell you today, which makes me very happy. So usually I come in and I do some soft shoe and I say, you can do a little of this, a little of that. Well, actually we have some data today and I'm going to be spending some time talking about that. Here are my disclosures. I work in medications and I have them, support from companies with clinical supplies. My objectives today, we're going to focus on factors linked with culture, epidemiology, and comorbidities for people with stimulant use disorders. We're going to talk about best evidence, not all the evidence, but the best evidence for medications for methamphetamine and cocaine use disorders. We're going to always remember we deal with whole people, and that's going to be a theme that I want us to adopt in our practice moving forward from today, is to remember that people are more than their disorders. And then infrastructure pain points that prevent or discourage culturally competent whole person care for substance use disorders, stimulant use disorders, and what you can do as a clinician in your setting. So let's start first of all with a case. So I'm going to ask you to at the end of this, choose what you want to do here and put your choice in the chat. Your patient is Jolene, a 37-year-old Caucasian woman. She's been using fentanyl and cocaine for the past year. The fentanyl on the streets is so strong, and for the last 6 days, Jolene was so high on fentanyl and cocaine, she was unable to move, sat in her own waste outside a metro stop, and developed open skin wounds with infections. When she lost all consciousness, her fiance called 911, and Jolene was transported to the hospital where she was cleaned up and treated with IV antibiotics. You've managed Jordan's opioid use disorder with buprenorphine sufficiently that she's not eloped from hospital, which is always a good thing. During her week, you order HIV test, and guess what? She tests newly positive. Her viral load is 1.2 million copies. Infectious diseases starts treatment for her new case of HIV infection. But as part of her comprehensive treatment, what is your preferred plan for addressing Jolene's cocaine use disorder? Do you A, remember she's in hospital, do nothing? Do you B, refer Jolene to social work for dispo, back to community? C, do you start a medication like mixed amphetamine salts, 60 milligrams plus topiramate, 200 milligrams? Or D, do you get Jolene to a drug-free rehab? Please vote your conscience. Please put your choice in the chat. Let's see here. Okay. I can't see the chat, Maya. Are you seeing responses? What are you seeing?
Yes, it looks like we have a lot of C's and D's.
Okay. All right, excellent. So you're going to learn as a result of the evidence today that the best answer here is C. First of all, this is wonderful that Jolene was actually treated for her opioid use disorder in hospital. That doesn't always happen. And then the idea of treating her cocaine use disorder in hospital is really great to think about. Linking to drug-free rehab is probably not the best idea, and we'll get to that in a few minutes. So we want to start the discussion today to talk about how stimulants function in the lives of people. I'm a clinical psychologist. When you pull a drug out of the functioning in a person's life, you actually leave a big hole. There's something that's missing. And when you're talking about working with whole people, you have to think about ways to fill that hole in ways that don't involve drug. I want to start at the top and talk a little bit about methamphetamine and how it works for gay men. Gay men stimulates the desire for sex. It facilitates a particular kind of sex. It enhances body feel. There's all kinds of ways in which methamphetamine works well with gay men. And it's been adopted largely across the country and around the world as a drug that's used to party on with gay men. Moving down, you can see the shift worker. Costs a lot to live in our towns where it often requires 2 jobs to be able to pay 1 rent. And methamphetamine or cocaine can actually help people to meet the goal of paying the rent. Bikers and biker street gangs, they can sell these drugs. They can actually provide a lifestyle. Continuing clockwise, we see women Women are almost as equally involved with stimulant use as men. And part of the reason is because stimulants help women be able to get their housework done or their jobs done, provide their child care, be able to be interested in sex when their partner comes home, and also lose weight. So there's really very little bad that happens. And for women in terms of methamphetamine, it kind of really helps in a lot of different ways. Rural people, youth, you can see how it helps. It can be useful to just help time pass. So pulling methamphetamine out of the repertoire in these settings makes things kind of hard to tolerate. And then finally, this new, as we continue the clockwise move, is about homeless folks. I live in Los Angeles, where we have about 70,000 people on the street any given night. And so we see these sorts of opportunities here for people to be vulnerable. And methamphetamine helps people to be able to make it through the night and stay awake. So that reduces the risk for harm. And so the idea of taking methamphetamine away from someone who's living on the street actually increases threats to harm and risks. And so there's all kinds of ways in which the work has to proceed. And on the left, you can see this is fairly clear. The green is the ups and the reds are the downs, and even the downs aren't bad. So the stimulant behavior repertoire is actually something that's built on positive reinforcing for many different ways. When we look at the number of people who are using stimulants in the misusing stimulants in the US in the past year, these are data from the latest national survey on drug use and health. You can see there's quite a few folks, 3.6 million. Most are using cocaine, about 3 million prescription stimulant use, and about 1.7 using methamphetamine. I think it's interesting to see that this flower shows that there's some overlap in terms of what people are using on the street, but not so much. People do tend to have an allegiance to the drug they misuse. And we can see that there is pretty much a representation across race ethnicities, with just a significant difference only seen between white and non-Hispanic Black Americans. In terms of folks who are using methamphetamine, Joey Palomar published these data showing from the National Survey on Drug Use and Health that across the population, prevalence tends to be about the same, which is about less than 1%. But in groups that are already drug engaged, methamphetamine use is increasing over time. And this is only increased through time with reported heroin use and also reported LSD use. And for those of you who are in grad school, this Reuter paper in addiction is really something important to read in terms of understanding epidemiology. I use this as a way to remind us that, you know, when we look at these surveys, the surveys are only as good as the people who answer them. So just something to think about as you're driving around town. With methamphetamine, we see, and cocaine as well, we see a co-occurrence. It's a syndemic of infectious diseases. These are data from Los Angeles County Division of HIV STD programs showing that in new cases of HIV, and the heat maps here, red is more cases, you can see there's a corresponding link between the cases being linked close together in space, but also with syphilis and HIV. And you can see here that that's what's happening. This is downtown, this is Hollywood, and this is the Figueroa corridor through South Los Angeles. And you can see that this cluster is the area where we have many social needs. One of the things that we also see in here is that among the HIV incident cases, 18% have methamphetamine use, 11% are unhoused, 2/3 have anonymous sex partners, and just under 50% have co-infection of syphilis. Syphilis and HIV and methamphetamine go together like bread and butter. So when you have methamphetamine, this is new for you guys in Boston, you're going to start to see this infectious disease shift as methamphetamine takes over in town. And of course, what does this have to do with opioids? Well, this is data from Joe Friedman and Chelsea Shover. The latest data showing on the opioid overdose, on the overdose crisis, you can see that fentanyl with stimulants is almost equivalent in terms of deaths per 100,000 rate to fentanyl with no stimulants. It's a very important point. One of the questions that people ask is, well, what is death like with fentanyl? or stimulants. And the answer is people don't typically just like do a lot of stimulants and then fall over and die. What happens is each time you use methamphetamine or cocaine, you actually take a hit to the cardiovasculature. And that hit is cumulative over time. Here are data from acute heart failure in the national inpatient sample. I'm sorry, this is so dated. I wish I had data that was more current, but it just doesn't exist yet, showing that stimulant-related acute heart failure hospitalizations are increasing during the same period you see the increase of fentanyl and methamphetamine. So what happens here is that increased hit to the cardiovasculature actually is something that is, it adds up over time. Among my pals in cardiology, there's a rule that if you have someone in front of you who's having a heart failure and they're under 40 years, unless proven otherwise, it's stimulant related. And so this is how much of the substance use issue is infusing within the specialties like cardiology. And we need to bring this back to worry about people's cardiovasculature when we're treating them for stimulants. One of my pals, Philip Coffin at UCSF and the San Francisco Public Health Department, is now recommending the use of statins as a prevention, as a harm reduction approach to working with people who are struggling with their methamphetamine use or their cocaine use to be able to sort of reverse some of the damage that's going on in the cardiovasculature. And this is why I'm here today, because we have this for the first time ever, a clinical practice guideline on the management of stimulant use disorder. This is from ASAM and AAAP. If you don't have a copy of this on your desk, you need to download it. It is filled with all of the best evidence for what I'll be talking about today, using medications to treat stimulant use disorder. And one of the first places it starts is what is the appropriate goal if we are going to treat people with stimulant use disorder? Should it be complete abstinence, or are there other goals that we can be thinking about? This is also percolating up into the community of scientists who are doing medication research to think about what is the appropriate goal. If no one can achieve complete abstinence right off the bat, why do we have that as a goal? A recent paper by Nora Volkov from a massive review of electronic health record data showed that there is benefit to reducing methamphetamine use. These are data that we published a couple of years ago showing that same sort of thing, but actually showing that social and health outcomes are actually enhanced for people who reduce their methamphetamine use over time. These are 500 gay and bisexual men who have sex with men who we've been following for 10 years here in Los Angeles. Most, 40%, are African American, 40% are Latino, half are infected with HIV, and half are living without HIV. But what we can see here, the probability of condition, the odds go up this way. What we see is a regular difference in differences outcome in terms of weekly or more use, showing more probability of the condition, monthly or less use, showing middle levels, and non-methamphetamine use, showing lower levels of whatever the condition is. And it's consistent across all of these variables over time: unemployment, housing instability, intimate partner violence, anal intercourse partners, concurrent sexual partners, exchange sex, positive STIs, if living with HIV, detectable viral load. In fact, one of the major factors in viremia for people living with HIV is consistent methamphetamine use, concurrent methamphetamine use, renal conditions, and neurological and psychological conditions. So there are measurable benefits over time to just using less meth. So this is a challenge to the treatment community where we imbue our people with the idea that abstinence is the only outcome worth doing. But there are data that are accumulating that are consistently showing that there are some strong health benefits to just using less. When we think about medication development for stimulant use disorder, here's the standard. There are no FDA-approved medications for stimulant use disorder. That doesn't mean there's no data that says that there are medications that we should use. The problem with this is that there's no companies that are developing medications. So what we're doing is we're evaluating medications that are already FDA approved for repurposed situations. There's no pharmaceutical company that's going to market those medications after we have those signals. And what we also know is that there's the number of medications where we see effects are fairly small, where the strong effects are where there are strong effects. And by strong effects, I use a really strong criteria, which is the hardest thing in science is to do the same thing twice. So seeing RCTs that are replicated showing the similar effect is really the best and the most stringent evidence. As well, large, fully funded studies, like upwards of 400 people, that's going to be able to give some sort of confidence that what you're seeing there is a signal. What we see instead is people using medications for symptom relief, and they'll see some weak evidences. We're not going to spend time on that, but we are going to spend time on these small suite of medication that have strong evidence of efficacy. And as we go into this, the strength of evidence in the practice guideline, the first thing it starts with is contingency management. If contingency management were a medication, it would be standard of care. The effect size of contingency management across multiple systematic reviews and meta-analyses is about the same as antibiotics for treating infections. So this is really, when I say if it were a medication, it would be standard of care. And hats off to the reviewers who put the clinical practice guideline together to recognize that whether you're using a fishbowl here or whether you're using an incentive, a voucher approach, this is the strongest way to proceed. So one of the first things we think about in treating whole persons is to think about ways to get contingency management to our patients. There are data for cognitive behavioral therapy and motivational interviewing, but it's weaker and it's not anywhere near as consistent as what there is strength for contingency management. And that's why we really are excited about bringing in contingency management into our treatment settings. So in terms of the strongest evidence, we're going to start with methamphetamine use disorder. This is a trial I was involved with, which is extended release naltrexone, or Vivitrol is the trade name, given every 3 weeks injection plus bupropion, the antidepressant, at 450 milligrams a day oral. And we'll also talk about mirtazapine, 30 milligrams a day, and see what happens here. Here are the data on the combination trial of naltrexone and bupropion. It's a sequential parallel comparison design. So people are actually randomized 1 to active to 3 placebo in the first stage of the trial, which is the first 6 weeks. And you can see here the percentage of negative urine samples is significantly higher for the medication group compared to placebo. During this period here, this shaded period, there are 4 opportunities to provide a urine sample. If you have 3 of 4 of those minimum urine samples negative for methamphetamine use, that's a success. If you don't have that, it's a failure. And at this period here, between the last visit in 6 to the first visit in 7, for the people in the placebo condition, you have a 1-to-1 randomization of active to placebo. Remember, you've got 300 subjects over here compared to 100 here. Then you have, again, around 150 in each of the groups over here. And you see, again, the emergence of it's a somewhat weaker signal, but you can see it over placebo for producing negative urine samples. And the difference between the 2 conditions here is 11.1 percentage points. The number needed to treat at 12 weeks at the end of the trial is 9, which is consistent with most addiction medicines that we use. Now, because these people here only counted once, we don't see them again in the analysis. We go only to this part. So the sequential parallel comparison design actually is a retest sort of approach. And one of the questions we asked was, what happened to these people after they hit into the week 7 to 12? Michael Lee, a junior faculty in my group, did some analysis here to see what happened here. And here's the folks that were in the first medication condition for 6 weeks. In week 7, what we see is a continuing, and in fact, a significant improvement of negative urine tests provided through time. So what we see is the slope continuing to go up like this. We don't necessarily see asymptote. And one of the questions we're going to ask next is, what happens in the next 12 weeks of treatment? Should we recommend continued treatment of this combination for people with methamphetamine use. Another junior faculty from Columbia, Jeremy Kidd, and Sabrina Smiley from UC San Diego, checked to see what was happening in the group of people who are men who have sex with men and women, gay and bisexual men versus men who have sex with women only. And what they found was that the treatment effect for gay and bisexual men was significantly greater than for the heterosexual men. Not quite sure what this means. It's certainly, Jeremy has put this together to be an R01 to see if this secondary analysis can be seen in prospective study, which is, of course, the best way to use science. And secondary analysis is to generate hypotheses. But generally speaking, this is a very strong effect and difference. So I'm not quite sure what that's about. And we've had some discussions about that, and we're going to be looking for that. But in terms of the combination, medication combination is the strongest signal of efficacy in over 30 years of addiction research for medication. For methamphetamine use disorder, 403 participants, fully powered. We saw the primary outcome response in both stages. 450 milligrams of bupropion is a significant dose of a weak stimulant, and many people, about a third, actually asked for a reduction from 450 to 300, which we actually provided in a double-blind way. And it's something to think about as you work with your patients. Extended release naltrexone produces a significant dose of full mu opioid antagonist and kappa opioid antagonist. This is also very important, the kappa point. The combination of these two, we don't think it's one and one, we think it's some combination of the two, is providing this synergized effect, something similar to how Contrave, which is the same combination at a lower dose, is showing efficacy for weight loss. But the constituents of the combination don't. The alternative here is mirtazapine, 30 milligrams a day. This was started by Grant Colfax in the early 2010s and repeated by Phil Coffin more recently, and showing that 30 milligrams a day of methamphetamine in gay and bisexual men and trans women shows a significant reduction of methamphetamine positive urine samples compared to placebo over 12 weeks. You can see that line there. It's replicated here, about the same level. The slope is very similar here and here. And then Philip actually did an extension to 36 weeks and saw that once the benefit was gained, there was no gain to continue at 36 weeks. So there wasn't too much of a resumption of use, but there was no continuing reduction of use compared to placebo. In meta-analysis, what we can see is that the medication is working here to reduce methamphetamine positive urine screens at 12 weeks. And that's the significant effect here. It's not in treatment retention, and it's not in managing depression. Mirtazapine is an antidepressant, but as it's working for reducing methamphetamine use, it's not happening because that people are less depressed, or you're treating a depressive response to reducing your methamphetamine use. I'm really excited about mirtazapine because it does the hardest thing in science, which is the same thing twice. The slopes are right on top of each other. The efficacy side is about the same as for the combination. What I think is that what's happening here, the likely mechanism is restoration of sleep architecture. 30 milligrams of mirtazapine actually will help you sleep better. And so we know that many people who stop stimulants, one of the major complaints that leads to return to use is problem sleeping. So sleep architecture is really important in recovery, and mirtazapine is helping. Just a side note, 15 milligrams of mirtazapine, don't use that one. It actually turns out that the hunger, the eating is stronger in 15 milligrams than 30 milligrams. And so then you have a weight gain problem that's more pronounced in the lower dose. So we talk about that here. And we have an ongoing trial now in Australia. It's a very large study in Australia in outpatient clinics, a randomized controlled trial led by Rebecca McKeaton. I'll keep you posted on how that goes. So another case. Miguel's 35-year-old Latino male with severe methamphetamine use disorder who recently had his first heart attack. Miguel is a dedicated father and hardworking shift worker. The methamphetamine helps Miguel work as a drywall hanger, an additional gig as a Lyft driver. On Friday afternoons, Miguel blows off steam by having casual sex with whomever is hanging around the Home Depot men's room. Miguel is a good family man and meets his family responsibilities. At your clinic, Miguel completed STI screening and he tested positive for syphilis, though he's never had it. Miguel tells you he doesn't believe his health problems are in any way linked to his methamphetamine use. He's unwilling to do much about his situation as he can't afford time off work for repeat health visits and he can't afford the co-pays. While in clinic, Miguel is treated for syphilis and says he's willing to try one of the new medications for methamphetamine use, but he can only come in once a month or so. As a practitioner, what would be your top goal for his treatment plan? A, do nothing. His words and behavior show he's not ready for treatment. B, schedule a meeting with Miguel's wife to discuss her current health risks. C, prescribe mirtazapine 30 milligrams each night. Or D, mandate 30 meetings in 30 days. So vote your conscience, A through A, B, C, or D. What do you think? Maya, what are we seeing?
Yes, it is overwhelmingly C as the answer.
Yay! Awesome. Thanks, guys. I appreciate you listening. And also, one of the things to consider as well would be to add a statin as well, right? Because he's using meth and he's in that 35-year-old range and you want to protect that cardiovasculature. So thanks. Okay, for cocaine use. My friend Frances Levin at University of Columbia has done some extensive work looking at mixed amphetamine salts extended release. This was the trial that started her work. It was with adults who have ADHD. And one of the things you can see here, this is the percent cocaine positive urine samples. Here's another signal that we see in science. It's called a dose response effect. Here's placebo, and you can see this has the highest rates of cocaine positive urine samples over the 12 weeks. In the middle group here is the middle group of the mixed amphetamine salts extended release and the higher dose, 80 milligrams, showing the strongest results here. Fantastic. This is very exciting. And I know Frances was very excited about it and followed it up with a couple other studies here showing that mixed amphetamine salts with topiramate in adults who don't have ADHD showed the same response. Here we have the 3 consecutive weeks of negative urine samples collected twice weekly, one of the strongest gold standard markers of outcomes. And you can see that in one randomized placebo-controlled trial led by John Mariani, you can see that there's almost a 2-time response here over placebo in terms of reaching that goal. It's actually exactly twice that this very hard to reach goal. So something is happening here in people who don't have ADHD. And Frances replicated this recently, showing this nice reduction in positive urine samples for cocaine over 12 weeks compared to placebo, where you see no response. So fantastic. So we have this one trial in people with comorbid ADHD with a higher dose showing higher response. And here we show in people who have no ADHD, you see a replication finding of the trial of extended release mixed amphetamine salts and topiramate. So what is going on here? Well, this is really a strong evidence of using this treatment combination. Some people will say, I don't feel comfortable prescribing mixed amphetamine salts to people who are adults who don't have ADHD. That's fair. But the data show that if you add this topiramate 200 milligrams with the stimulant, it seems to work. Topiramate by itself has a weaker signal. So the idea of combining the two, actually that synergy of the combination seems to be what's happening here. And in here, I think this whole issue together, that these 3 studies together with similar signal signs provide strong evidence supporting use of stimulants to change neuropsychological underpinning of attention and impulsivity that are involved in continued cocaine use. If we look here at just using stimulants alone, here we have the Tardelli meta-analysis. This is the most recent meta-analysis showing that even just using stimulants alone, you find a significant effect over placebo across multiple studies, including Francis's and John's and other folks' studies through here. What we also see in here is that that in this group here we have folks that are looking at more well, actually I don't have the data in here, but I'll just tell you, get to the point. The point is the stronger the stimulant, better the effect. So things like atomoxetine, which are weaker stimulants, show weaker signal, less consistent effects. Things that are stronger, like mixed amphetamine salts, methylphenidate, other sorts of stimulant full agonist approaches seem to have the better outcomes. For cocaine use disorder, there's a strong dose effect and this consistent response. And the issue here is about the need to educate the field to think about using stimulants for cocaine use disorder. Still, many clinicians are going to be uncomfortable with this approach. So the outcomes are that we have this small suite. Now we've been through the small suite of medications. So we have for methamphetamine, mirtazapine, and we have the extended release naltrexone and bupropion. We have for cocaine use, we have the mixed amphetamine salts extended release plus topiramate. So these are really showing that there's a foundation of treatment for stimulant use disorder. And I talked at the top about the whole person approach. We're not going to talk about just using medications. We're going to talk about the whole person. But before we get there, I just also want to point out that for psychotic symptoms in the practice guideline, there's strong evidence showing that antipsychotics work. So when people are coming in floridly psychotic, agitated, the primary way to treat is olanzapine and quetiapine from the data, but you can use other antipsychotics and they will work fine. You treat until the resolution of symptoms occur. You may want to add a benzo. That's also positive. That's also supported by the literature with the idea of reducing the symptom. You would not use mirtazapine or the combination or any of the cocaine-related sorts of medications that have stimulants in there with people who are coming in with agitation. The first thing you're going to want to do when people are having florid psychosis that's related to their stimulant use disorder is to resolve their psychotic symptoms. And here are the citations for that, the practice guideline, and also you can see Seyfried's analysis here. For withdrawal, we know that withdrawal lasts for a week, 2 to 3 weeks, or 1 to 6 months. And one of the first things we see is that stimulants, ammoniptine is the only medication that has strong effect for reducing withdrawal symptoms. It's off market in most parts of the world. There is inconsistent signal for biomedical treatments on methamphetamine withdrawal as well as cocaine withdrawal, with symptom relief being the primary driver here. In terms of thinking about how we use this sort of information, one of the things we want to talk about is professional biases and competencies in treating stimulant use disorder. It's not the same thing as treating opioid use disorder. We need to understand the different type of treatments, and we have them listed here: medical, behavioral, community, that are necessary for success in addressing stimulant use disorder. There's a whole set of things to do here, including focusing on the identities of the person. Versus the person who uses stimulants is going to have a different identity than the person who primarily uses opioids. I have data that's coming out showing that's exactly the case. So using it like a Suboxone or a buprenorphine to treat people who use stimulants and co-use opioids is not going to be a successful approach. Whereas using the same medication for people who are primarily using opioids and co-occurring using stimulants is absolutely the way to go. So it's just that issue of the identities that we talked about at the beginning. Cultural factors in addressing stimulant use disorder in gay and bisexual men, men who have sex with men, and trans women. These are really important. If you have folks coming into your offices that are gay, bisexual men, trans women, and you don't have any sort of art or representations of these communities in the clinic space, that's seen as somewhat of a lack of cultural competence. Similarly, the same thing for ethnic race minority identities. Having culture, art, pictures, things around that actually reflect people from these communities can be very helpful. focusing on economic factors. I've been treating people with stimulant use disorder for a long time. More and more recently, the issue of managing economics as a factor in sustained recovery is something that I now have to address. And of course, thinking about reducing harm to women and pregnant persons who seek help for stimulant disorders is important. One of the best things to do is to do academic detailing. I did this recently in my clinic. I walked in and I said, oh my God, this place looks like a parole office. So I actually had people go through and bring in some plants, bring in some art, bring in some pictures. These sorts of things can happen over time where we just get tired and don't pay attention. So the whole idea about whole person care is to do silo busting. And the idea here is to build these crosswalks between the expertise in terms of infectious diseases, addiction treatment, and primary care. And so to close, we're going to do one last case here. Our patient is a 32-year-old African-American man, James, who's an out gay man. You've met with him once already, following referral from his primary care provider. He tells you about his concerns over his cocaine use, especially fears that this fentanyl or xylazine may be in the supply he's buying. Today's appointment was for 9 a.m. At 9:45, still no sign of James. He hasn't called. You finish your next appointment. You walk the individual to the waiting area. It strikes you the clinic is sparsely furnished with white walls and few faded framed pictures, some silk plants, and some outdated magazines. As you look around, you also see James walking out the clinic door. At the front desk, the staff member says James arrived at 10:15. The next available session for James is 2 weeks from today at 9. James was agreeable and rescheduled. Which of the following is something that would be helpful to change to ensure James is likely to return to clinic and once there, keep his future addiction medicine appointments? A, do nothing. James is scheduled for 2 weeks in the future at 9 a.m. B, follow James out to ask if he would spend a few minutes with you in your office. C, get a urine screen from James to confirm recent cocaine use at your next session. Or D, require James use treatment goal of absolute abstinence. So vote your conscience here, folks. What are you seeing, Maya?
B, mostly B for everybody.
Yay! Right. B, scheduling a person with stimulant use disorder at first in the morning is really a bad idea. Don't do it. They don't, especially if they're involved in active use at different times or return to use, they're just not going to show up. And 2 weeks in the future is completely fantasy. It may help you feel better because you actually did something, but they're not going to show up. So the idea to step out and have a few minutes is really a good way to go. And to think smartly about scheduling, getting people into the noon or after hours actually is going to help people to show up. So strong evidence, we talked about this. I really want to focus on the bottom part of the slide here. The culturally competent treatment is built upon the power of the repeat visit. Get people back in. Use liberal structure, positive reinforcement, expertise and effects of stimulants on behavior, and try to remember that you need to build people back up as they've fallen apart. Commitment to integrated whole person treatment and respect for cultural differences commitment to reducing bias and stigma. And I'll stop here for questions. Thanks all.
Steve, thanks a million. That was masterful review and a very hopeful one too. Thank you for giving us that really nice current update on the latest evidence. And also, by the way, we've got the download for the guideline that Steve showed us in the chat. Maya put it in the chat. So please click on that and download the latest guideline. We've got a few minutes for questions and comments. Have you been keeping track in the chat
Yes.
with the comments?
Yes, we've had a couple come through the chat at different points in the presentation. One person asked if you could report on any side effects reported with mixed amphetamine, salts, and topiramate.
Okay, great question. So mixed amphetamine salts and topiramate, the onset of the stimulant is slow. So you're going to have just manage some people's understanding of that. The major side effect is with the topiramate. Topiramate can have some cognitive side effects that are difficult for people to tolerate. It's like they like to say, "I forgot where I put my life." You know, in the patient community, they say it's not Topamax, it's Dopamax. It's like this is something that people have to struggle with. And being able to support folks during this period in the sort of the neurocognitive fuzzy can be very important to help people get through some of that. Now, some people like Kyle Campman has done something by starting at 25 milligrams and increasing dose week over week by 25 milligrams to build to 200 milligrams is an approach that has some efficacy to address that issue of the neurocognitive side effect.
And then we had another question as well that two people kind of reflected, and feel free to unmute yourself if I'm misrepresented, but Beth and Carol both asked, the question is, does that work on fentanyl addiction as well? I believe this was at the point when you were speaking about mirtazapine, but feel free to correct me for the people who asked that.
Mine specifically was, what is the best combination? So I can't pronounce it, mirtazapine is good for the meth use, but what about for fentanyl? What would be your combo suggestion that works effectively for fentanyl addiction?
So the best answer is we have no data on this. So there is very little data on fentanyl plus stimulant treatment showing bits of efficacy. So part of the problem is, you know, if you have the medication combination of extended release naltrexone plus bupropion, you've got an opioid antagonist, and most people who are using fentanyl are not going to want the opioid antagonist. So that pushes you to the mirtazapine if they're using cocaine, methamphetamine, and so then you would have buprenorphine or methadone for treating their fentanyl use disorder, and then potentially adding the mirtazapine 30 milligrams. Now, that, like I said, you know, we have data only from people who have primary methamphetamine use disorder for the mirtazapine. There's no reason why it wouldn't work in people who have opioid use disorder and also using fentanyl. And it is the only opportunity, that's the only evidence-based treatment that I know of you would move toward. If you're using cocaine, because a lot of people will use cocaine with fentanyl, the idea of adding the stimulant with the adding mixed amphetamine salts, extended release plus topiramate, I think would best be managed by someone who is a psychiatrist and feels comfortable giving that sort of stimulant treatment for people who are who have severe opioid use disorder or fentanyl use disorder. I think it's possible that it could be something that would work. The evidence is there, but I think the risk and the patient management issues would best be managed by a specialist, which is something for me to say because I'm in family medicine, and you know, most of this stuff can be managed in primary care settings. Most of the stuff that I'm talking about today as the foundation of treatment can really add to the opportunity for people to meet their substance use goals. And, you know, adding in the idea of, you know, contingency management or cognitive behavioral therapy or some community-based response or 12-step, and including ands wherever you can, as opposed to ors, it actually builds the likelihood that people are going to have a positive response. So I'm all about the and.
And we have another question too. Barbara asked, how can we make MAT mainstream?
We do it. So one of the things that's happened in Medicaid is that Medicaid will pay for most of these medications. Now I've given this talk lots of times, and they'll say, "Hey, Steve, we can't get extended release naltrexone every 3 weeks." So, and that is true. Many of the insurance companies, including the private insurance companies, will not provide for that. What I can tell you is we have no data on this, but I do know that in the community, providers are having people have 7 days of oral naltrexone 50 milligram tablets during that period. There's no data that says you should do this. So I'm just saying that is something that you can do to keep those naltrexone levels consistent so that you can start the next month with the extended release naltrexone for 3 weeks. The issue of the extended release naltrexone is it does appear to have a substantial decay curve in weeks 3 and 4. So providing some extra oral naltrexone during that period of weeks of the 4th week makes a lot of sense. And as I said, you can find ways like by prescribing for depression and for alcohol use disorder to get some of these medications covered. So the idea of using these off-label medications is something that is being picked up in practice. And as we think about bringing medication-assisted therapy for people with stimulant use disorder, this is something that the prescriber community can take up and push policy. So unfortunately, policy is slow to change at the high levels in terms of covering these medications as they're coming off, because there's no pharmaceutical house that can get you the FDA approval that is going to give you that automatic ability to prescribe. And it would be an incomplete answer if I didn't say lobbying for ways to get contingency management available for everybody is important. I live in California, where we have CalAIM, which is a $599 episode of contingency management that's available for every resident in the state of California. So it's fantastic. We're learning a bunch of stuff about how you spread this stuff out widely. Contingency management's been adopted in the VA system, but yet no private company has picked this up yet as a treatment approach, which for those policy researchers would be a great policy question to work with a private insurance company and test what happens if you integrate contingency management into treatment compared to standard of care in their covered practice, in their covered patient base. So another reason to keep working.
Steve, we got a couple of minutes left. Just one thing on the contingency management front. One of the things that the people talk about with CM is the lasting effects. And if once you remove the contingency, how long do the effects last? And could it be a segue into something else that would be more self-sustaining, or what does the data look like once the contingency is removed and other things come into play?
So 1 year post contingency management looks like 1 year post cognitive behavioral therapy. So, the idea of, the sustained recovery is important, but we also have the fact that this is a chronic relapsing condition. So the issue of being able to measure improvements at the end of the year is important. There's a new paper out showing meta-analysis that 1 year effect is strong compared to other things, and that 1 year analysis is really about as strong as cognitive behavioral therapy. So those are good talking points to come back about, just kind of thinking about, like, we're willing to pay for cognitive behavioral therapy, but not contingency management, yet the effects are about the same or maybe slightly better, but they're in the same neighborhood. So the issue of reducing the incentives is like not a good question. I reject the question. So I say, if you take a medication away and it stops working, that's evidence that the medication works. If you take contingency management away and the effect goes away, it's a problem with the therapy. So it's just an inconsistent logic.
And is there habituation how long could you keep contingency management going for a year?
I don't think so. I wouldn't. I've done 12 weeks, and about 12 weeks is the time that people are ready to do something other than contingency management. So contingency management it's an interesting psychological thing. What goes on in the box, the black box of people who are in contingency management, is still the study that's not been unpacked yet. But it is not, we do know that it causes it causes changes of the D2, D3 receptor. And so there's a neuroscience thing that happens, but we also know that the people want to move on and they want to explore other things in their lives. And that's that whole person thing of the recovery is a piece of their life, but they want to enhance that. And that often leads them to more formal treatment settings, or begin to think about engaging in faith-based work, or joining the 12 steps, or doing other things that bring joy in their lives.
Well, Steve, I think, one of the things that was really encouraging, I think, for a lot of people to hear was for me anyway, was your pragmatism. You're a pragmatic guy, but also a top-notch scientist, and marrying those two things. You talked about the hard science, but also about putting art on the walls that's culturally relevant in your clinic, that kind of thing, marrying those things to look at the big picture, the whole picture, as you put it, was, I think, very important. And there's not a lot of scientists that are thinking along those lines. So thank you for bringing that, Steve, that, your perspective. I think it's a really important one myself, that we cater to these things that we don't often consider our science, but they make a real difference to patients in terms of attracting, engaging patients in our clinics and keeping them engaged in treatment. So we're out of time, unfortunately. I wish we had more time for more discussion. But Steve, thanks a million for that masterful overview, and like I said, a very hopeful one. Thanks everybody for coming today. We really appreciate your participation. Please spread the word about the ORN and the free consultation that you can get, that clinicians can get on contingency management, for example, that Steve's been talking about, and many other things. So pretty much anything that is game. If you want to get training, education, technical assistance, go to the Opioid Response Network.org. It's free. Please spread the word. Thanks, everybody. We'll see you next time. And let's give Steve a hand and thank him for his great talk today. You got a lot of love in the chat here, Steve.
Thanks. It's great. Thanks for having me.
Yeah. Well, it's great. And people love your energy, by the way. We haven't told them that it's morning in California, but you got a little bias there. But thanks a million, Steve.